What I'll try to discuss with you today are the changes with regards to aging, extraoral and intraoral aesthetic as it relates to implant placement. There are about 57 well-established clinical studies that, if you look at the general data from those studies, it is pretty clear that aging and craniofacial changes occur throughout life. It occurs to bone, occurs to soft tissue, and it occurs intraorally. This is predictable. What is extremely unpredictable is the time of onset, exactly the magnitude, and the vectors and forces that take part. So let me share with you some of those cases that we have tried to control and what happened to us. The first patient received, she was born missing 8 maxillary teeth. We placed implants at the lateral position. In 1993, she was in the late 20s. In 2008, that is 15 years later, the remaining maxilla continued to extrude, with resulting tremendous extrusion of the 2 centrals, but also severe thinning over the 2 laterals. When you look radiographically, you can see the distance between the apices of the centrals and the lateral, and compare it to 15 years later. And these are adult patients. If you do the measurements, you have extrusion of about 4 millimeters. And that's in a female, so the extrusion of the maxilla will be down and in. This patient I have treated at age 70 and placed implant at the premolar area. At age 80, in 97, he fractured the lateral and the central was missing. So we kept the canine and went and placed a bridge from lateral to lateral, from the right lateral to the left lateral. At age 92, we have 3.5 millimeter extrusion of the canine because the maxilla continue growing. And clinically, he lost complete posterior occlusion because the implants act as an ankylosed unit. A 70-year-old patient, a female, we placed double molars at lower right. 3-4 years later, open contact described in all our literature. Now this is much easier to solve. You just redo the crown. This patient is an interesting one. She presented at around age 50s with a broken molar. I performed sinus graft and a veneer graft. And it's interesting because the reconstruction was completed by 2009. And 3 years later, we're opening the contact. That means that the grafted bone did not behave as a separate bone, but behaved like the anatomical structure, meaning the sinus itself. It behaved like the maxilla itself. It moved with the maxilla and the opening contact. So what are the changes and what have I done in the last 5-6 years as far as surgical changes? And this is information that I will try to share with you. There are variations in craniofacial structure. We have to pay attention to that. We will talk about aging, we'll talk about onset, and we'll compare males and females. We'll talk about implant diameter. We'll talk about macrostructure of implants. How do we change it? We'll look at growth variation. And the important part surgically is what did I do with, or what do I do with the osteotomy today that I haven't done years ago? And what kind of reconstructive surgery is needed? Let's look at some variations. You have much less risk in a normal face as opposed to the long face or the brachiocephalic face, because changes in the long face and the short face will be much more dramatic. What about aging, onset? Do male vary or are different than female? It took me quite a while to get from few radiological centers a full CAT scans of the head and neck. There are really few indications to get CAT scans of the whole head and neck. And I try, though it's 3 different patients, of course, but we're comparing here 21 years old, 57 years old, and 76 years old females. it's very clear the degree and the opening and how obtuse the mandibular angle becomes. You'll also see that the length from nasion to the end of the alveolus increases with age. To summarize those changes, I put it in 2 dimensions. If you look at a young female, the mandibular angle is 110, 120 degrees, and is a given length from nasion to the alveolus. These changes with growth, the mandibular angle becomes much more obtuse and much greater. And in females, the maxilla will grow down and in. That will explain exactly crowding in the low incisors in females with time. If you assume that you do that angle, say, to Sella turcica, and you compare the young and old, I don't think that you need any explanation here to the changes that will occur. What about male? Here we got 3 CAT scans of 3 different males, 36 years old, 55, and 89. Male grow in a very different direction. In male, the mandibular, the ramus gets longer, and there's some auto-rotation. But the mandibular angle does not increase to the same degree. So in 2 dimensions, to illustrate to you the changes, if this is the young male and the old male, we will have elongation of the ramus, slight auto-rotation of the angle, downgrowth straight down, not lingually, of the premaxilla, with those kind of changes that occur. Now imagine the implant is fixed in structure. It does not move. So it will not exactly cooperate with those type of movements. What about dimension as far as the jaw? All the data indicates that you increase the interincisal distances in the molar area. It will be more in the second molar. It will be slightly less in the first molar. It will be slightly less in the first premolar. And the arch length is being reduced. So the initial thought of surgery and placing in the middle of the ridge may be wrong. Because what does happen is lingual resorption, which is much greater in the second molar, and apposition of bone on the facial. So we have increased intermolar distance, and at the canine area it stays the same or even actually reduced. So to simulate those situations for you, we took a lower jaw, we introduced some resorption, and now the center of the ridge is not the center of the ridge, and it will explain to you why the replacement of an implant of a tooth at the lower second molar often will result with time with bone resorption and thread showing on the lingual. And with time, there'll be more resorption. And when will it occur? We do not know. But it does, and it keeps on resorbing and resorbing. Now, what about diameter selection and bending force? This is something I learned from Steve Herson. The initial, Thorsten just discussed it as well. The initial Brandenmark implant was 260 megapixel for bending. Implants today are much harder, and therefore I would not hesitate as far as strength to use an implant that can withstand like a 4.3 replace tapered, 320 Newton at 30 degrees, 5 million cycles. This is amazing strength. And if you look at a 5 millimeter, that strength is not even applicable, it's so strong. But that means that my placement in certain areas has changed, taking into account the diameter and the make of this titanium. So here we're looking at the posterior maxilla. And this was my direction of placement at second premolar, molar, and second molar. And I thought to myself that 2-3 millimeters of bone on the facial would be adequate. And all of you, when you go back to the office on Monday, you will see resorption and thread showing on the facial aspect of the posterior maxilla. To the anterior one, we'll get in a second. This is not acceptable because these are the results. So you need to reconstruct, and facial reconstruction of 3, 4, 5 millimeters predictably is not that simple. So you have really two options: play with reconstruction or play with diameters. Whatever the case is, this is problematic long term. So I always will reconstruct facially, and I will take into account the diameters of the implants. The same will happen, as I showed you in the mandible, where I would go with a very wide body implant replacing a second molar. And the result will be that we will have some resorption on the lingual, and the threads will be showing, and we will assume that that is because the patient is scrubbing. And that's not the truth. So if we go with this type of width of an implant, you may be better off to reduce the diameter, select a slightly narrower, and have sufficient amount of bone and tissue on the lingual aspect. What about macrostructure? That may be strange for you, but not for me. I like implants that are retrievable. That means once you have to retrieve a site, and once you operate in an aesthetic zone, and that has to be removed, you better not have implants with sharp threads. You better not have implants with high pitches. You better not have implants with sharp back cuts or vents. And therefore, whenever I expect growth, and we are talking only about adult patients, because the young ones we don't place, and you saw a range of 25 to 90, I will use the Mark IV replace tapered, the Mark IV or the replace tapered, because it's easier to remove and it's less traumatic. That's what I do. Growth variation. It appears that it starts earlier in female than male. There are many, many theories. But generally, the curve in a male is between 40 to 50. You go through a very rapid change in growth. In female, it starts a little earlier. Now, since we all agree that we will not place implants at juvenile, if I see a female at age 40 that will tell me that she feels that the growth, she's aging, she feels a big change in the last 2 or 3 years, she may be on this tangent of growth and this tangent of aging that if I place an implant, I will always be wrong. So there's nothing wrong when there are this tangent and suddenly aging process occurs. Wait for 2 to 3 years and place then. What about surgical changes? We have to modify osteotomies, and it's a very difficult one to do right, and it's very difficult to teach right, and it's very difficult to change the old way to go. But it's possible. Now let's assume that we have a ridge B, and this used to be my right direction of placement. I would leave myself 3 to 4 millimeters of facial bone, so I will be sure that I'm within the bone and I'll have little resorption. Today, this will change. I will go more lingually. Well, if I'm going more lingually, I have a risk of exposing lingual threads. And since female and male grow in different directions, anterior maxilla, we have to accommodate to that. So if my initial placement in a female would be along this red line, I will have to go well lingually to that and translate the point of entry and the point of access superiorly and inferiorly. And that means that I may have some threads exposed on the lingual, and that means I will graft. In male, to remind you, growth is straight down in the anterior maxilla. So I have slightly lesser risk, but nevertheless, it has to be taken into account. Again, the point of entry will be changed, and you may select a narrower diameter. And 1 or 2 millimeters makes a major difference. Because this resorption that is predictable and will occur to some degree with all females has to be accounted to long term. In the posterior maxilla, there are further modifications. Let's assume we have a ridge B and more bone 3. This used to be my direction of placement. I felt comfortable in having sufficient amount of bone both facially and lingually. But no more, since we resorb facial lingual in the posterior maxilla. I have to allow myself to have more bone on the facial aspect. That means that if I will move lingually, I will have to graft. So we really have here three basic options. Graft, change the angle of placement, or change the diameter. Quite frankly, I do all three. You will not see me place a 6mm implant now in the anterior maxilla, or a 5mm. It looks good on a socket, you guarantee aesthetic risks. And how about reconstructive surgery? And I think that this increased in the way we practice. For what I showed you, we augment lingually, we'll augment facially, especially in a ridge that is slightly knife-edge ridge or narrow ridge. Anticipate any mistakes or any growth or any changes that will occur to bone and soft tissue. So if you do have to do all three, start from the lingual. It will always also graft, of course, vertically. One thing that changed with the grafting is that I used to always use autogenous bone, and I used to use some substitutes as well. But primarily on the large defects was autogenous bone. And here's an example where we went in a very different direction. The area, very knife-edge ridge, severely resorbed. I grafted with a J graft, I grafted with lingual graft, and then I added non-resorbable grafting material. And the reason is very simple. Remember the case with the sinus, that the bone graft behaved like the sinus now, not like a bone graft. The same happens here. I know that I will have resorption and growth in the anterior maxilla. Therefore, this bone will behave like native anterior maxilla bone. So adding a non-resorbable to the autogenous bone at least will allow me to have some connective tissue, which is better than, or scar tissue, which is better than no tissue. So now we have the ridge reconstructed. That's about 8 months later. And here we have a delineation of where I used to do and what I would do today. I used to place it between those two blue lines. Today I will be certainly lingual to the lingual line. Now here we get into a very difficult situation. These are the patients with a high smile line, high aesthetic demands. We told them that they will have an implant, it will look like a tooth, and then we place it at 40, and at 45 they will be extremely unhappy. So we have to retrieve the site. We have a site that resorbed, the rest of the teeth extruded, the alveolus extruded, the bone is diminished in dimension facial-lingually, and the bone is apical. We remove the implant before, place an implant in our new directions, augment the facial, so we cover up for future possible growth. Again, we'll use some non-resorbable in addition. We'll advance the flap, over-advance the flap to allow for some growth and some remodeling and some changes, and reconstruct. This is a situation a patient is extremely unhappy, and you would say, well, it's only 2 mm discrepancy, but it's for her, and she's in front of cameras, and that's not acceptable. When we open the site, you can see the degree of bone loss on the facial, and it's well apical. Again, reconstruct the site, advance close primarily, over-advanced, and now the implant looks better than the tooth. The point is that since that growth is unpredictable, you always have to be prepared for it to go, for the growth to occur, and how do you get out of it? The way I look at implants today is very much like a lighthouse. The lighthouse is a fixed structure, and the scenery is always the same. Doesn't change. But once bone resorption, craniofacial growth occurs, and all, the lighthouse stays. The scenery changes. The conclusions are very simple. We cannot control aging. We cannot control bone changes. We cannot control 40 to 50 to 60% bone volume loss in a face and a mouth. We can therefore not control contraction of muscles and soft tissue. What is needed from our profession who deals with reconstruction is more or less a time dependent techniques, both in techniques and devices, that will stay the same over time. Thank you very much.